Perfect. Hello, everyone. Welcome to our webinar today. I hope this roof hammering is not too disruptive, but we'll get going anyways. I'm just recording because several folks signed up who couldn't make it, so we're just going to have a recording available for them. If you have any questions throughout, please feel free to pop them in the chat. We will hopefully have a little bit of time at the end to answer any questions. You can also, if you don't want it to be public, you can always do it as a direct message if you'd prefer, and hopefully we can get to those. I'll do my best to allow time for that. So welcome to our webinar on PCOS. It's titled "It's Not Your Fault" because we'll get to the reason why, but it really isn't. So we want to talk about, PCOS diagnosis and a lot of the guilt and shame around it, and why we shouldn't be that way. So just a little bit about me. My name's Dr. Emma Furs. I am a naturopathic doctor here at Clementine Natural Health. So I'm part of an amazing team of doctors here. And, it's a really great place to practice. My clinical focus is in women's health. So pelvic, gynecological, skin health. And I don't really mention this a lot, but I think it is kind of relevant when you do have a special interest in a topic. To share that, and it does help you empathize a little bit more and understand where your patients are coming from. But I was also diagnosed with PCOS about 6 years ago, so I get where my patients come from. I've been there, so it just kind of adds that extra little touch, right? Just a quick disclaimer. So these following slides, this is really intended for education. So the idea here is just to, maybe teach you something new about PCOS, whether you have it or you don't. We will go through some treatment options, but again, really isn't medical advice. If you have been diagnosed with PCOS or think you might have it, recommendation is just to consult with your doctor, or me if I'm your doctor, or if you want me to be your doctor, that's also cool. But just before we begin any self-prescribed treatments, herbal remedies, anything like that, reason why is that sometimes there are side effects, there are contraindications to things. So we just want to make sure, that everything is done prescribed by a doctor and to make things as safe for you as possible. So again, this is just educational, but thank you for joining me. So what is PCOS? A great question. And it's also really difficult to have a solidified definition of the condition because there's so many varying degrees of clinical presentation and hormone involvement. So ultimately, it is a very complex endocrine and metabolic disorder. A highlight of it is marked with ovarian dysfunction in some way that ultimately leads to abnormal hormone levels. So, Lara Bryden, a women's health ND and researcher, she really breaks it down into 4 main types of PCOS. Now, the first one is insulin resistance. Now, in my patient population and, the general people we see, that this is about 70%. So this is the most common by a long shot. And, it's mostly what people see. However, not everyone has insulin resistance. So we have to think about other types. With 1 in 10 to 2 in 10, somewhere between that range of women having PCOS, it is so common. So then we can just think how common insulin resistance is amongst our population. A couple other types are pill-induced. So this might resolve on its own. It's a temporary surge in hormones after usually stopping the pill. An inflammatory type, again, non-classical, so less than about 3% of people have this. And then same with the adrenal PCOS. This is the lean type athletes and can sometimes be post-pill induced. But again, really not as common. Should still be considered in populations like that, but insulin resistance are big hitter here. So assessment. So what do we do when someone comes to my office and says, hey, I think I have PCOS, but I'm not sure. Or they do have PCOS. We're still going to assess them because I always want to be able to confirm the diagnosis. However, this does depend on the population. So it depends on who's there and the age and what their goals are. So adolescents, we have a risk of over or under diagnosis. This is because during adolescence, your hormones are still fluctuating quite a bit, as well as follicles on the ovaries. Several follicles can actually be very common at this age, which can be mistaken for polycystic ovarian syndrome. So little bit risky there. And then when we look at preconception, so this is really talking about risk factors. So there was a really large meta-analysis in 2006 that looked at the PCOS and pregnancy outcomes that involved over 15 studies and about 800 patients with PCOS. It was found that patients with PCOS were more likely to develop gestational diabetes, hypertension, preeclampsia, preterm birth, and have babies admitted to the NICU. So that's something to keep in mind here. If someone comes to me and says, I'm thinking about getting pregnant soon and I want to conceive, and whatever your timeline is, we have to work to support that PCOS, ideally before you conceive, to improve clinical outcomes for the pregnancy and for your own health during that pregnancy as well. When we look at, same with pregnancy throughout, and then when we look at adults and menopausal women, this is very common. These are about the same approach. Here we're more looking at metabolic syndrome, diabetes, as well as risk for cardiovascular disease. So with that whole metabolic syndrome, we'll look at a lipid panel. Again, is a lipid panel as concerning in an adolescent at 18? Maybe not, but in someone in the menopausal range or postmenopausal, definitely something we're going to pay a little bit closer attention to, as their risk for cardiovascular disease already is higher than a younger woman. So assessment's really important, and we're going to keep talking about it. It's so important. Now, this is my general approach to assessment. So we're going to look at the left side of the slide first. Now, history. So case taking and taking a history is so important here, whether you've been diagnosed or not, or you think you have it. We still need to make sure that you actually do, right? So history is our conversation. We're going to talk about all aspects of your life. We're going to talk about your stress, your lifestyle, your job, your relationships, your hormones, your menstrual history, any other previous diagnoses if you have them, other health conditions. We can review your past labs. And then we ultimately make a plan and see what our next steps are for testing. And then we also, a huge part for this is talking about your goals, which we'll see come up more in treatment. But what are your goals? Like, what do you actually want? What I think might be important for you might be different for you. And that's okay. We're going to talk about it. So we always just want to make sure, I want to make sure I'm aligned with my patient for what their goals are and what is actually important, to support that. The second point here is a pelvic or a transvaginal ultrasound. A lot of patients will have had this done already in a medical, if they went to their family doctor and said, hey, I'm having this, it's probably one of the first things that's ordered. So sometimes people come and already have it. I will refer if we feel like we need to have it done, but PCOS diagnosis can also be made without it. So this is really depending. Sometimes it is also useful to rule out other conditions. So if we're thinking maybe it's fibroids or endometriosis, and we want to just see how overall health of the pelvic area is, we can always include that as well. Blood tests. So this is this is where a really comprehensive approach comes in. The only actual marker for a diagnosis on a blood test is actually going to be testosterone or androgens, because that's part of the PCOS diagnosis. Now, everything else we're going to order is, helps complete the picture and helps us look at everything, because that's what we do. We look at the whole thing. So here we can look through luteal phase hormones. We can look at FSH and LH. We can obviously look at your androgens. A lipid profile might be a part of it to assess your risk for cardiovascular disease. Again, with insulin resistance being such a huge player here, we're definitely going to look at glucose, insulin, and hemoglobin A1C. And then other things we can also look at are inflammatory markers, just your general blood count. I think it is still a good idea to have labs done on somewhat regular intervals, also depending on your age, your goals, and stage of life. But it really just helps complete the picture. Now, the next point is a physical exam. So This isn't diagnostic for PCOS. However, it might be a part of it. So we might want to check your blood pressure. If you also have complaints of bloating and, maybe abdominal pain is a part of it, we might want to do an abdominal exam. So although it's not part of specifically this diagnosis, it still is a part of the whole assessment that we're going to do together. And the last part is ultimately, we've done steps 1 through 4. My job is to come up with a diagnosis for you. So, we have to think about, yes, it could be PCOS, but there's also other conditions that present like PCOS that aren't. So we have to think about like hypothalamic amenorrhea, congenital adrenal hyperplasia, straight up diabetes, a thyroid condition, POI. So there's a bunch of different things that, could present like PCOS, but then once we do our assessment and really go through things, it actually isn't. So we always want to keep in mind those things. And then coming up with a diagnosis. So now we're going to look at sort of the right side here. We look at the Rotterdam criteria. So this is encompasses 3 different things, such as cysts on ovaries, signs of hyperandrogenism. So this is things like high androgens, whether it be in your blood or clinically. So clinically, we would see this as cystic acne, hirsutism, or unwanted hair growth. And then oligomenorrhea or amenorrhea. So either having really long cycles or no period at all. Now, coming to a diagnosis here, this is where a little bit of confusion comes into play a lot, where you actually only need 2 out of the 3 things to be diagnosed. So in terms of here, we talked about a pelvic ultrasound, but that's going to show us cysts on the ovaries. That's actually not always necessary if you had the other 2. Yes, it might help us see other things going on, but it's not always a thing that we need to include here. So that's something just to keep in mind. That, only 2 of the 3, sometimes you might have all 3, you might just have 2. And that's where the different types of PCOS also comes into play, that not everyone's going to have cystic acne, high testosterone, and unwanted hair growth, right? So something to keep in mind. But that's also my job to figure out those things. It's not you, but we can always work. We're going to work together on this anyways. So this is the question that I think as practitioners, we get asked a lot. How did this happen? What happened? What did I do? And if any of my patients were to Google PCOS, they're going to get a plethora of answers as to why it happens. You ate too many carbs, you got PCOS. You have a high sugar diet and that led to insulin resistance. So you got PCOS. And it's actually like totally not true. So the literature pretty much says we don't know. There's some ideas floating out there. So a lot's related to genetics. If your mother has PCOS, you're more likely to have it, that type of thing. Epigenetics, so and kind of goes with environment. So how our environment can alter our genes. But there isn't a definite answer. It's not like you did one thing to cause your condition. And I think this is really important when it comes to blame and shame around the condition. So a lot of people feel bad about it, especially when it comes to cystic acne, clinical signs that someone can see. Maybe they're concerned about their weight. Maybe they have unwanted hair growth that, they're shaving all the time. And it affects ultimately people's confidence is the most common thing I see. And then they're going to go to their family doctor and they're going to say, well, you did this to yourself, stop eating carbs and you're fine. It's so unfair. And it frustrates me so much to see that as a regular answer. So a lot of my patients come in really feeling bad about themselves and feeling like they did something wrong to get this. And I just really like to confirm that it's really not your fault. If we knew why it happened, it would be out there, right? But we don't. So if you are a practitioner and you have a patient come in, just really don't blame them. Don't say, there's some things, there's a lot of conditions out there that we know. We know the number 1 cause of lung cancer is cigarette smoking. Okay, fine. Great. We know, alcoholism can cause liver problems. Okay, great. But here, there isn't a one size fits all. There isn't a reason, and we just don't have the research to know. So it's not really fair to pass that blame on to our patients and make them feel bad about themselves. Oh, I lost my tea here. There should be a T there. I swear I can spell. So what's next or next? What's next for you? This is going to depend on your goals. So I think it's really important, again, talking about that history, that assessment part of that for me is saying, okay, what are your goals? What would you like to do? Because that's going to change for people depending on their age, their stage of life, what they think is important. For some patients who come in, they're saying, my cystic acne drives me crazy. It's uncomfortable, it's painful, my confidence is down, I hate it, that's my number one concern, I want to get rid of acne. Okay, cool, we're going to do that. Someone else might say, I want to conceive in the next year. Okay, we're looking more on the fertility side of things. Treatment generally is going to be very similar. However, just keeping in mind how we're going to measure that outcome. So how are we going to know if our treatment's working for this person with acne? Well, their acne will go down and they will feel better. They'll, maybe less breakouts, less cysts, less pain, whatever that is for them. Whereas how are we going to know if our treatment for this person whose biggest concern is fertility? Well, maybe their acne might get better, but that's not what they were most concerned about. So are they going to have a successful conception? Are they going to get pregnant soon? Right. So we always have to keep in mind what a goal is. And that's how we although treatment generally for the condition is quite similar. If someone has high androgens or someone doesn't have high androgens and that's not part of their clinical presentation, well, we're not going to focus on the treatments that decrease androgens, right? So a lot of them sort of hit all areas, but just thinking that I like to keep a goal in mind because I like for people to be able to see that a treatment's worked and have measurable outcomes, whatever that is, whether it be clinically or through blood work. Okay, so this is something where I always keep in mind someone's history with food, their relationship with food before we make any suggestions here. Now, I screen for disordered eating and disordered eating habits in all of my patients, and it's really important. So some patients want dietary recommendations and they're able to implement them, and some can't or shouldn't because of their history with disordered eating. And that's okay. So my job is that I think about these things before I even go to food, right? For some people, it might be a simple swap or a simple addition of nuts and seeds every day, and that's okay. I personally don't subscribe to diet culture, and I always, still encourage my patients and support them, eat the treats, eat what makes you feel good, but also keep in mind what literature says in terms of your condition and how we can support that through nutrition as well. So it was shown, women with anovulatory cycles have a bit of more trouble with appetite regulation, based off of also high insulin. They just generally struggle with nutrition-based ideas and how they feel. They use food for different reasons. So although, again, I'm weight neutral in my practice, I have to, present the literature. I can't say that this isn't a thing because the literature has shown that weight loss of 2 to 5% reduces things like high insulin. It increases sex hormone binding globulin, which will decrease your androgens, and it helps restore ovulation and improve clinical features of those high androgens, such as acne and hair growth. And I'm just here to present the literature, but again, my treatment varies and what someone wants to commit to is able to. Again, we also have to think about things like, food resources, food, what's available to them as well, and what changes can be made, and what's also going to keep them happy. So ultimately, we look at clinically relevant endpoints in the literature that supports the results of restoring ovulation, decreasing acne, hair growth, and maybe some people want to see a change in weight. Doesn't matter if they do or don't, it might happen just because of this. So this is all about energy balance. So we're going to look at protein intake. This will help increase satiety, feeling of fullness, decreasing dairy for acne. Lowering starch in general does improve blood work and help satiety because we're eating more protein as well. So we sort of balance that way. A really interesting study in 2015, they looked at PCOS women for 8 weeks with this low starch and low dairy nutritional approach. And they saw that, fasting insulin, 2-hour insulin, and the HOMA-IR, which is sort of your glucose to insulin calculation, was reduced by pretty much like 50% risk in almost all 3 areas, as well as androgens were significantly decreased. So it is there in the literature. We can't deny it. Something I find personally really interesting is AGEs, or advanced glycosylated endpoints, which are a byproduct and are mostly produced in processed foods with dry heat technology. So it was also found that patients with insulin resistance, so again, 70% of our PCOS population, consuming these AGEs, they generally have more ovarian dysfunction, more inflammation, and more insulin resistance than if they ate the same amount of calories in other foods. So we know processed foods aren't great for us. Everyone knows that, but this at least gives an actual studied example of how and why this works in PCOS specifically. Because everyone's going to say, oh yeah, I don't eat processed foods. But if we say like, actually it's the AGEs, it's kind of cool to know, right? Flax, walnuts, almonds, all great, all studied well. Ultimately, balance is key. Eat whole foods. I don't believe in food rules. I prefer to add rather than subtract in my patients. So I'm always going to say, let's talk about adding more protein. How can we add more flax, walnuts, nuts, and seeds, things like that, rather than taking it away? So that's my approach. Again, I'm super sensitive on the topic of food, but I think it is important to bring up in PCOS because it can make a difference, and the research does show that. Okay. A treatment option for supplements. So I could do an entire hour-long talk on this, 2 hours long, because they're very well researched. There's been a lot done here, but I just want to say, for the most part, these are the best choices for clinically relevant outcomes. I could double or triple this list to show everything that's been researched at all, but I think these are sort of the top, 6 heavy hitters on supplements. Ultimately, for different mechanisms, the idea behind all of these is we're looking at decreasing androgens in one way or another, restoring ovulation in a period. We're looking at blood sugar regulation, so berberine, inositol, really good for that. We're also looking at antioxidants and things like that. So I could talk about the research on this for hours. I don't think it's that relevant right now. And also lipids. That's another thing I forgot to mention, just with that omega-3 and such. So there's a lot of options. Again, because this is just educational, I'm going to leave it there. But most of my treatment approaches will look at a combination of these supplements in one way or another to, support all the other things we're also doing. But it's there, it's important, and that's sort of the main list that's the most well-researched. So medications, again, we're looking at clinical outcomes. So we want to improve blood work and symptoms, and how are we going to do that? And also, what's the goal? There's like a really common theme here. It's not your fault, and what's your goal? Those are our 2 big ones here. So oral contraceptives, IUDs, progesterone, metformin, just a couple to list, right? Goal, again, like we have to think, if you're trying to get pregnant in 6 months, we're not going to give you an IUD. That's pointless, right? Like that's not our idea here. But do we need to give you metformin for your blood sugar, right? Are you like on a diabetic or on the verge, right? There's lots of different things to look at. And each thing has its own purpose. Each thing has its own time and place to use for medications. So yeah, I think this is so case by case, and I don't think I can say like, I'm going to give everyone spironolactone, because that's just like not the case. But these are the options. These are all available to naturopathic doctors in BC. We can prescribe these. So lots of really good players here that can make a huge difference. But again, case by case situation on what you need in your life. So this is probably the most common thing I'm going to prescribe for anyone is a lifestyle. And I know, and this is also going to be whether you have PCOS or not, whatever your endpoint diagnosis is, whatever, it's like these really just apply to anyone, but especially PCOSers. So 7 to 9 hours of quality sleep. I know that's a big goal, but also something we can work together, support that way. I say high quality because sometimes people get 7 hours of crappy sleep and it's not the same, right? Sleep is so critical, so important in aging processes. So I just think that is a non-negotiable, and I'm going to tell everyone that. I'm going to stand on the top of Gross Mountain over there and yell it to everyone that they need to sleep. Stress management, so it's huge for everyone. Most patients I see are stressed in one way or another. So we just want to think about how we can work on that together. Movement daily. So this lovely lady on our screen here is going for a walk. Whatever movement means for you. I'm not going to prescribe an exercise routine. I'm going to say do what is best for you, what feels good, what you enjoy, what brings you joy, what you like to do. For me, this changes all the time. I go through phases of being a walking person. I go through my Peloton phases. I go through no running, never. Maybe, yeah, like, and then I want to like lift weights for a while. Like it whatever feels good. Who cares, right? And then drinking water. So just a basic foundation of health, hydration. Every cell in our body needs it. Keep drinking your water. So in summary, we don't know how you got it. It's not your fault. Don't blame yourself. Stop it. I can hear you blaming yourself from here. Just know that it's something that can be treated though. So there's lots of options. I know I briefly brushed on several of them, but it's so case by case, and because it isn't one size fits all. I'm never going to prescribe the exact same thing for everyone. There's lots of options, but we can talk about it. We can talk about your goals, that kind of thing. And just a parting note here, it's not going to be cured. So people who, girls on TikTok love to say this, I cured my PCOS. No, you didn't. You just know how to manage your symptoms. So it's not going to be cured. It's never going to go away forever. But my goal with working with you as your doctor is that we're going to manage it. We're going to help you, get your period back, get pregnant, do whatever it is, get rid of your acne, decrease your hair growth, that kind of thing. We're going to work together and do that so that you can ultimately live the life that you deserve, right? So that's sort of my goal. And it's about management and it's about sustainability. So that's why, again, like these crazy dietary changes, things like, cutting out carbs, like it's not sustainable. And since this is a long-term condition, like what's the point in that, right? So that's a little bit about my approach, a little bit about some tidbits about treatment and diagnosis. And are there any questions? Thank you. You're welcome. Okay, I'm going to end it there. I hope everyone has a great rest of your day. Bye.